first question of day 3. Now the question is, a patient presenting to you with a palpable swelling per abdomen. So there is a palpable swelling per abdomen. The patient is a known case of chronic pancreatitis. So I have given you a lot of things so you can understand what it could be. A patient with chronic pancreatitis with a palpable swelling. Now this is the CT image shown. So I'll zoom the CT for you. So many of you are quite uncomfortable with reading the CT, but it's the easiest of all. So what are you seeing in this CT? Sir, here, so this is the vessel that you are seeing. So this is the location where you should be actually getting the pancreas. So this is the location. But if you see in this image carefully, the first thing that you have to concentrate upon is a cyst. There is a necrotizing cyst with solid and liquid collection. So there is a cyst with a solid and liquid connection. You can see here, can you see a well defined cyst with some necrotic collection here, and this is again the cyst. The distal part of the pancreas is not visible. So the first thing is, what is the grade of this lesion? Now you will say, sir, iski bhi grading hoti hai. First of all, identify what you are seeing. So you are seeing a pseudocyst. This is what is very important. So are you seeing a pseudocyst? No, exactly not a pseudocyst. You are seeing a wall of necrosum. So wall of necrosum you are seeing because of some necrotic component also present here. But anyways, let us see. If we talk about the pseudocyst or wall of necrosis, we have a classification for them. And what is that classification? Let us quickly understand that. So whenever we talk about the grading of pseudocyst, now this is quite new. Yesterday we saw much more new topics, and today also I will get 1 or 2 new things for you. So grading of pseudocyst, first of all, you should know that the classification that we used for pseudocyst or von, this is the Neelan's criteria. So we have a Neelan's classification or a Neelan's grading system. So what is this Neelan's grading system? The type 1, we according to this we have 4 types. We have type 1. What is type 1? Where the duct is there, I'll just quickly share with you the image basically, so that will help you understand all of them. So very quickly I will share with you. This is the first thing. So if you see, there is normal duct, there is no stricture in the duct. So normal duct and there is no stricture in the duct. Now this is a pseudocyst around the normal duct. If you see here, the cyst is connected. Again, what is type 2? If it is a pseudocyst associated with the normal duct, it is a type 1 Neelan's. What is type 2? If it is a pseudocyst associated with the strictured duct. So if the pseudocyst is associated with the normal duct, it is a type 1. If it is associated with a strictured duct, it is a type 2. The third is if it is associated with this, or you can say the duct has disappeared, the distal part of the duct has disappeared. So this is known as disappeared distal pancreatic duct. Disappeared distal pancreatic duct. This is also known as obliterated pancreatic duct syndrome. So अगर आपसे कोई कहता है कि what is obliterated pancreatic duct syndrome, you should know that when the distal part of the duct is not available, only one part of the duct is there and that is communicating directly with the what? Pseudocyst. So disappeared duct. And then we have a type 4. What is type 4? This is associated with chronic pancreatitis. This is associated with chronic pancreatitis. Now try to understand, if you see this image, we have type 1A, 1B, we have type 2A, 2B, we have type 3A, 3B, 4A, 4B. What is the significance of this A and B? एक तो चीज़ मुझे ये समझ में आ गई सर, अगर डक्ट नॉर्मल है इट्स अ टाइप 1, इफ इट इज अ स्ट्रक्चर्ड डक्ट इट्स अ टाइप 2, इफ इट इज अ यू कैन से ऑब्लिटरेटेड डक्ट then that is a type 3, and if it is associated with chronic pancreatitis duct then that is a type 4. Now try to understand one very interesting fact, that what is type A? Whenever we say 2A, whenever we say 3A, what do you mean by this A? If it is not connected, if the cyst is not connected with the duct, then that is what is known as type A. And remember, what is type B? If the cyst is connected with the duct, then that is known as type B. So if you see, यहाँ पर देखो the duct is connected, but here if you see there is no connection with the duct. Here if you see the duct is connected, here there is no connection with the duct. So 3A, 3B, 2A, 2B, 1A, 1B, you need to understand ये A और B क्या होते हैं, connection और non-connection. So what is the new classification that you have studied for the pancreatic pseudocyst? Neelan's classification और Neelan's criteria for grading of the pseudocyst. अगर pseudocyst normal duct के साथ है type 1, strictured duct के साथ है type 2, if it is associated with obliterated pancreatic duct, then that is type 3, and if it is associated with multiple strictured pancreatitis, chronic pancreatitis like you can say duct, then that is type 4. Now if you see exactly, if you see in this image, the distal part of the duct is not visible. This is very interesting. The distal pancreatic duct is not visible. So this is a patient with obliterated pancreatic duct syndrome. So the classical association is a type 3B. So what is 3B? Where the duct has been obliterated and it is connected. But I would not say it to be a type 4, even though the history is of alcohol induced chronic pancreatitis, but here you don't get to see that typical chain of lake appearance. So ye duct, this is the distal CBD, the distal main pancreatic duct has been obliterated. So ye type 3B ki criteria mein aayega. So one is very important thing. What is the approach to diagnosis? Investigation of choice for them is CET. Let us quickly understand what is the management of pseudocyst. Very quickly let us understand. Whenever we have the patient of pseudocyst, what is the next thing that we all need to understand? Observation. So treatment of choice is observation, and this is done for 6 weeks. Why, students? Because majority of the cyst will dissolve during this time, resolve during this time. If the cyst persists, so if cyst persists beyond 6 weeks, this is what is very important. So if the cyst persists beyond 6 weeks, the very next thing is what is their size. If the size is less than 6 centimeter, observation, this is what is important. If it is more than 6 centimeter, the very next thing that we have to understand is it symptomatic or is it asymptomatic? So more than 6 centimeter, if it is asymptomatic, so there are no symptoms versus there is symptoms. So if there are symptoms, the management is different. If there are no symptoms, the management is different. So if it is asymptomatic, the very next thing is size increasing. The answer could be no, the size is not increasing. Then again you will have to go for observation. तो इसका मतलब ये नहीं है कि अगर साइज 6 सेंटीमीटर से ज़्यादा है तो इंटरवेंशन करना ही है. If the size is not increasing, observation, but even if it is asymptomatic, the size is increasing, then you will have to go for internal drainage. Why? Because this is a type B. That means it is connected with the duct. Next is if it is symptomatic, the very next thing is it infective or is it infected? So if it is infected or infective pseudocyst, the answer could be no, it is not infected. Yes, if it is infected. But we cannot drain anything internally if it is infected. So therefore you have to go for external drainage. And how do you do an external drainage? Everyone knows that it is percutaneous external drainage. If it is not infected, then we have two things. We have the MPD stenting, main pancreatic duct stenting you will do. So the patient will have some relief of the symptoms, and then you will, if it fails, if the stenting fails to resolve this cyst, then you will have to go for internal drainage. And what is the internal drainage strategy that we have? cystogastrostomy. So you go for cystogastrostomy, which is also known as the Juras procedure. So cystogastrostomy, or we also go for transgastric stenting. So this is what is the complete management of pseudocyst. Let us quickly go to the next question. So a patient underwent a stent placement. देखो आज की IBQs में I have included some offbeat questions. Why? Because I'm not here to please you. मैं आपको अच्छी easy फोटो दिखाऊं, उससे कोई फायदा नहीं है बच्चे. The more you sweat in practice, the better you perform in the main game. So a patient underwent a stent placement for infrarenal AAA. पहली बात, when you go for the stent placement for an aortic aneurysm, what is it known as? This procedure is known as EVER. What is EVER? Endovascular aneurysmal repair. So this is endovascular aneurysmal repair. Now 2-3 questions related to this. Whenever we put a stent in the aneurysmal sac, what is the objective of putting a stent? First of all, sir, this patient will not be a candidate for surgery. So meanwhile, the aneurysm should not rupture. So we put a stent. Now what is so special about the stent? The stent is impermeable. So what is the advantage of this stent? The blood will try to go and cross this stent easily, not a problem. The blood supply to the aneurysmal sac is cut off. So the aneurysmal diameter will not increase. It may shrink also. गलती से अगर aneurysm rupture भी होता है, so if the aneurysm ruptures some fine day, that the problem is not there because blood supply to the distal limb of the vessel is still secured. So this is what is known as EVER. The next question is, sir, who is a candidate for EVER? Any person who is not fit for surgical intervention, they are the candidates for EVER. Sir, it can be done for thoracic. Yes, it can be done. Can it be done for all abdominal procedures? It can be done, but it is preferred for infrarenal. Why? Because suppose if this is done for a juxtarenal, try to understand, suppose it is done for a juxtarenal where the renal arteries are arising, then you will also have to place fenestrated stents, otherwise renal artery ka bhi blood cut off ho jayega. And aorta is having a wider diameter, but renal artery is not that. So there is a chance of RAT, renal artery thrombosis. So theoretical जो कहती है, थियरीज कहती है कि कहीं भी कर सकते हो, बट प्रैक्टिकली देयरफॉर इट इज प्रिफर्ड फॉर द इंफ्रारीनल वेराइटीज. नाउ द नेक्स्ट इज, what is the aim of doing this EVER? The aim of doing this EVER is the blood should not enter the sac, and if the blood manages to enter even after this procedure, this is what is known as endoleak. So dear students, let us talk about the complication endoleak, जिस पे ये question है, identify the endoleak. So first is, what do you mean by endoleak? Endoleak is defined as the entry of blood, into the aneurysmal sac after EVER. Then this is what is known as endoleak. Now there are 4 or traditionally 4, वैसे 5 भी हैं. So what are the types of endoleak? Try to understand. Suppose you have placed a stent like this. Now you are very happy, sir, that I have placed a stent and this is okay. So you have placed a stent. Now the blood is managing to enter into the stent and going out. It's okay. But can you see you have left a defect here and the blood enters into the aneurysmal sac, and this is where you have a persistent blood flow entering. So bachche, this is a type 1 endoleak which is due to the loose junctions. So the loose junction endoleaks are type 1. It could be type 1A if it is above, and it is type 1B if it is the below loose junction. The second thing is that suppose you have placed it properly. Now if we talk about aorta, lot of small vessels are arising, especially the lumbar arteries. Lumbar arteries are arising like this. So whenever you have placed a stent, so let me place a stent for you. So this stent is impermeable stent. Yes or no? Everyone knows that this is impermeable. So the blood will enter into the stent and will exit out distally, and there is no entry of blood here. So what happens? These lumbar arteries, they become ischemic. a message is sent to the body that lumbar arteries are not receiving the blood. Why lumbar arteries are not receiving? Because you have placed a stent. Now, do you know, for their rescue, the collaterals develop from the inferior mesenteric artery. So, when the body comes to know that the lumbar arteries are not getting the blood, there are lot of collaterals which develop in between the inferior mesenteric artery and lumbar artery, and thus the blood flows into them. When the blood flows into them, there is a chance that the blood might also enter into the sac. So, this is what is known as type 2 endoleak. So, type 2 endoleak, this is the most common variety of endoleak. That is why you must have noticed whenever you do an aneurysmal repair, you always close these lumbar artery osteums. So, this is what is very important. लेकिन endoscopic में प्रोसीजर्स में ये कम्बरसम होता है, इसलिए नहीं किया जाता है. सो रिमेंबर, टाइप 2, दिस इज एंडोलीक एसोसिएटेड विद बैक ब्लीडिंग, एंड बैक ब्लीडिंग फ्रॉम व्हाट? via collaterals originating from the inferior mesenteric. Remember, this is a emergency, very important. So, this is a medical emergency or surgical emergency, and what is the treatment of choice for them? You have to do coiling or blockage via embolus. So, angioembolization of the collateral vessels, this is what is the management. अभी ये दो समझ लिया बच्चे. कभी कभी क्या होता है, वी हैव अ टाइप 3. व्हाट इज टाइप 3? इमेजिन you have a long aneurysm. So, when you have a long aneurysm, there could be possibility that you need to connect two stents. So, when you have connected the two stents, you will have to establish a water seal connection. Many a times, the junction between the two stents might be leakage. So, this is known as because of the loose fitting between two stents. So, if there is loose fitting between two stents, then that is known as type 3. Basically, type 3 type 1 का ही एक modification है. Then we have type 4. आप मेरे को बताओ what is type 4? Very interesting. बच्चे, normally the graft that we used is impermeable. कभी कभी क्या होता है कि the graft material becomes porous, and if the graft material is porous, the blood might come out of this. So, what is type 4? It is associated with porous graft material, and that is a type 4. And when none of the cause is there, still it is available, that it is increasing in diameter, then this is known as type 5 endoleak, and type 5 is also known as endotension. What is endotension? Endotension is the type where because of the inbuilt tension, the diameter is increasing. It is not due to extra blood which is coming in. Remember, junctions are okay, fitting is okay, there is no back bleed. This is very important. अब फोटो देख के ही समझ में आ जाएगा कि सर कुछ ब्लड वापस आ रहा है. So, this is a endoleak, an endoleak associated with black bleed. So, I would say this is type 2. Is that clear? This is a junction or connector. अगर यहाँ से लीक होता, so that would be type 3. If the graft would be porous, then that would be type 4. I hope this is clear. So, the answer that we have is this is a type 2 endoleak. Let us move forward and let us understand this. Again, a question from GIT. A patient underwent a surgery for chronic pancreatitis. Name the procedure. So, now you have something in front of you. I have the pancreas has been resected. You can understand this is the CBD that you are seeing, this is the CBD, and you can see this is the duodenum and this is the pancreas, and you have done some pancreatico-jejunostomy. I would be very happy if you answer this question. What is the diagnosis? Bache, I hope you know what is Whipple's. Whipple's is defined as triple PD. What is triple PD, students? This is pancreas or pylorus preserving. I would have made this question tough by writing something else. I would have written PPPD, then DP, PH, lot of terms are there. I will tell about those terms in this question. So, first is pylorus preserving pancreatico duodenectomy. Bache, as the name is pylorus preserving pancreatico duodenectomy, यहाँ तो डिओडनम गायब हो जाना चाहिए. सो फर्स्ट ऑफ ऑल दिस इज नॉट अ विपल्स. अब आते हैं ये 4 प्रोसीजर. व्हेन वी टॉक अबाउट what is Pasteu's, what is Burns, what is Beeger and what is Frey. This is again very interesting. बच्चे Pasteu's is LPJ. What is LPJ? Longitudinal pancreatico jejunostomy. So बच्चे जब भी कभी हम pancreatico jejunostomy की बात करेंगे, there is no resection done to the pancreas. इसीलिए ये पस्टियाउस भी नहीं हो सकता है. व्हाट इज द अनदर नेम फॉर LPJ? द अनदर नेम फॉर LPJ इज दिस इज ऑल्सो नोन एज Partington-Rochelle surgery. So Partington-Rochelle modified the original, you can say, Pasteu's because the original Pasteu's had splenectomy also done. अभी हम splenectomy routinely नहीं करते हैं. So this is the Partington-Rochelle surgery also. पर ये भी नहीं है. Now you are left with Burn, you are left with Beeger and you are left with Frey. Now what is Beeger, what is Burn, what is Frey? Remember all these surgeries, Frey, Burn and Beeger, they are duodenum preserving surgery. So when we talk about duodenum preserving pancreatico duodenectomy, this is DPPD, duodenum preserving pancreatic head resection, DPPHR. मैं यही टर्म के बारे में बात कर रहा था. DPPHR, duodenum preserving pancreatic head resection. So if you see the duodenum is preserved, yes or no, but the pancreatic head has been resected, and this is what is the classical Beeger's procedure. So this is a Beeger's procedure. बच्चे what is the difference between Beeger and a Frey, and then I will tell you about the difference between a Frey and a Burn. बहुत सिंपल सी चीज़ है, दोनों को समझने की कोशिश करो. Let us understand all these things quickly. So whenever we are talking about the surgeries for chronic pancreatitis, it will hardly take 2 or 3 extra minutes and we shall understand each and everything about this. So good evening. So when we talk about approach to chronic pancreatitis, everyone knows that chronic pancreatitis, and I'm talking about surgery for chronic pancreatitis. बच्चे surgery सबके लिए नहीं करते. कब करते हैं? When you have intractable multiple episodes of hospital admission, not resolving to opioids or painkillers or whatever therapy. So when you want to do this surgery, the next is where or what is the location for the chronic pancreatitis. There could be 2 things. What is that? Sir, it is involving the, you can say, the tail of the pancreas. It is involving the tail of the pancreas, and if it is involving the tail of the pancreas, you know that distal pancreatectomy with splenectomy is the call. This is done. छोड़ो उसको. Next is, sir, if it is involving the branch duct, so if it is a branch duct pancreatitis, there are 2 procedures that we do. The first is Bickey's procedure. The first is Bickey's surgery or procedure. This is nothing but it is entire length coring of the pancreas, and along with that plus LPJ. This is one surgery. The second is you can go for total pancreatectomy. Do you know the exocrine function of the pancreas can be maintained by taking exogenous, you can say, lipase. So we have that, you can say, Creon, we have Enzar. But what about the Langerhans cells? Because endocrine function depends upon the Langerhans cells. So along with that, auto implantation of Langerhans cells into portal vein. So you got 2 questions ki what is the site for implantation of, you can say, or transplantation of the pancreas. Answer is into the portal vein. बच्चे हमें सिर्फ और सिर्फ Langerhans cells के लिए, I'm talking about the Langerhans cells, the endocrine part. Anyways, come back and understand what about if it is a main duct pancreatitis involving the head. So if it is involving the head or the neck or the body, how do you approach this? So head and neck, this is what is very interesting. The next thing is we will only go for surgical intervention if the duct is more than 6 mm in diameter. So the duct diameter is of paramount importance. If it is more than 6 centimeter, more than 6 mm, I am saying 6 centimeter, or less than 6 mm. If it is less than 6 mm, you can go for the stenting. Remember, the duct, the surgery is not done for them. If it is more than 6 mm, the next thing is it associated with head mass? Point number 1. So is it associated with head mass? Is it associated with jaundice, obstructive jaundice? Is it associated with strictures along the duct, or is it associated with stones? So if the answer to them is yes, if the answer to them is no. So if the diameter is dilated, if the diameter is more than 6, that is main pancreatic duct. So main pancreatic duct MPD diameter is more than 6, बाकी कुछ भी नहीं है. In that case, you will only go for what procedures? For the drainage procedure. And what is the classical drainage procedure that we have? We all know this is only and only the LPJ or modified Pustyaus procedure. So I have already taught you what is Pustyaus procedure. This is known as the longitudinal pancreatico-jejunostomy. बच्चे यहाँ पर कोई रिसेक्शन नहीं करते. If we go for the second category where the head mass is there or maybe jaundice is there, you need to understand that head is having the highest concentration of stellate and myofibroblast cells. So in that case, you will have to go for drainage and along with that resection procedures. So drainage plus resection, and when we talk about drainage plus resection, we have two kinds of surgeries. One is the duodenum sparing surgeries and the second one is duodenum sacrificing surgery. When we talk about duodenum sacrificing surgery, I have already told you pylorus preserving pancreatico-duodenectomy, and this is known as Whipple's. And when we talk about duodenum sparing surgeries, then the next thing is we have the duodenum sparing pancreatic head resection procedures. This is what is very, very, very important. So duodenum, you can say sparing pancreatic head resection, or we do coring of the head mass, and along with that you do LPJ. So if you do coring of the head mass and LPJ, then this is known as a phrase procedure. If you do the duodenum sparing pancreatic head resection, then this is what is known as Beager. पहले तो इतना समझो, मतलब है the surgery that you are seeing here, we have resected the head mass. Can you see? We have resected the head mass and you have gone for Roux-en-Y pancreatico-jejunostomy. So if the head mass is removed, उसको Beager बोलोगे. अभी burn पे आएंगे, don't worry. When we talk about the phrase, what is phrase? Try to understand. Suppose if this is the pancreas and this is the head mass, you can understand this is the duodenum that we have, this is the pancreas, you can say ligament of Treats. Now in phrase, you don't do the head mass resection. Imagine this is the pancreatic head, so you will just go and curate the head. So this is known as coring or curettage of the head, and once you have done the curettage of the head, you will open up the pancreatic duct, and when you open up the pancreatic duct, you can get the jejunum and you can do the pancreatico-jejunostomy. This is what is very, very, very simple. So this is known as the coring of the head mass, coring plus LPJ. इसको कहोगे phrase, and do you know phrase surgery is the most popular surgery. Very good, very good. Now understand what is the burn modification of the Beager. Now this is very interesting. Burns modification of Beager surgery. अब इसको समझने के लिए थोड़ा सा दिमाग समझो. What is Beager? Sir, in Beager, this is the duodenum. Sir, I have divided almost entire head and I have separated the pancreas. This is what is known as the Beager. This is what is known as a Beager. In Beager, the head is resected. Try to understand. The Beager, the head is resected. What is done in Frey? The head mass is curated, not the head. बच्चे, when we talk about the burn modification, in burn you don't resect the entire, you can say entire pancreatic head, rather curettage of pancreatic head, not only the head mass but entire pancreatic head. वो कहता है head mass नहीं, पूरा pancreatic head almost curated, but don't expose, don't resect the head, and then you can again do the what, students? The pancreaticojejunostomy. So बच्चे, burn में भी pancreatico रू एंड वाई pancreaticojejunostomy करते हैं, बीगर में भी रू एंड वाई करते हैं, बट इन बर्न यू डोंट रिमूव द एंटायर हेड, इन बीगर हेड को रिमूव कर देते हैं. इन फ्रे यू डोंट डू रू एंड वाई, यू डू LPJ. You can do a रू एंड वाई, that is okay, that's a longitudinal pattern of anastomosis that we do, and here we do end to side and you can say side to side anastomosis. This is what is very important. ये हो गई end to side, this is end to side रू एंड वाई हेपाटिकोजेजुनोस्टोमी. सो फ्रे में सिर्फ हेड मास निकालते हैं, बीगर में हेड को निकालते हैं, बर्न में हेड को पूरा रिसेक्ट नहीं करते हैं, यू क्यूरेट द एंटायर हेड. इज दिस क्लियर टू एवरीवन और नो? सो दिस इज व्हाट इज द answer, that why it is not burn, why it is not burn, it is beager. Is this clear to everyone or no? Let us move forward. बड़ा अच्छा क्वेश्चन था ये. Not many of you understand about this. Okay, now again an offbeat question. What is this defect? First of all, ये defect दिखना चाहिए, defect समझ में आना चाहिए. This is an image that I have taken from Campbell and Walsh. Sir, I could see that this is a bladder, point number 1, and I can also understand that this is the ureter. So you must have heard of Weigert-Meyer rule, yes or no? So what is Weigert-Meyer rule? In case of duplication of the ureter, the lower ureter is normal, the upper ureter is ectopic. The lower ureter opens at the trigone, the upper ureter opens below the level of trigone and medial to that. अब समझने की कोशिश करो. So this is the first ureter which is normally going and opening here. So this is what is the opening that we are seeing. बच्चे, पर can you see this ureter? This is opening here, but actually this is grossly dysmorphed and you can say dilated cystic ureter, yes or no? So dilated and along with that dysmorphed ureter, and this is what is known as ureterocele. So पहली चीज है, the image that you are seeing, this is ureterocele. Point number 1. Sir, where is it associated? This is associated with duplex ureter system. Generally when you have two ureters, so duplex ureteric system, then that is where the chances of the abnormal ureter becoming dilated like a cyst, this is what is known as this is the place where you have a chances of ureterocele. अब एक बच्चा कहता है सर बड़ी मुश्किल से पहचाना कि ये यूरेट्रोसील है. अगला क्वेश्चन होता है कि सर ये कौन सा यूरेट्रोसील है. नाउ दिस इज वेरी इंटरेस्टिंग. whenever we talk about the ureterocele, how we identify the ureterocele, this is important. So identification is the opening of ureterocele. This is really very interesting. So let us go and understand few important points about the ureterocele also. बच्चे ये सारे क्वेश्चन आ गए तो you will just cry, otherwise you don't have any clue. यहाँ पर तो वो भी नहीं, निमोनिक विमोनिक भी नहीं लगा सकते, मुन्नी बदनाम हो डार्लिंग तेरे लिए, blah blah. So let us talk about ureterocele. When we talk about ureterocele, it is the cystic dilatation of an abnormal ureter, abnormal cystic dilatation. Next is how to identify the ureterocele. So I will create a small bladder in front of you, and now this is the ureter which is opening, and this is how the things are. But if you see, the ureter is opening inside the bladder. So this is, there are few important things that we need to understand. So identify the location of opening, ureteric opening into the bladder. Now let us try to understand. बच्चे, if it is into the bladder, if it is into the bladder, then that is known as intravesical ureterocele. बच्चे intravesical ureterocele. Now, if it is not located at the bladder, it is located at the level of, you can say, bladder neck. So, if it is located at the level of bladder neck, then that is known as sphincteric. This is what is interesting, sphincteric. If it is located below the bladder neck, then that is known as extrasphincteric or ectopic. Remember, if it is associated, if any obstruction, any component of obstruction is there, then that will also be added with what? Stenotic. So ऐसा भी हो सकता है कि intravesical stenotic, sphincteric stenotic, extrasphincteric stenotic type. ये कुछ चीजें हैं जो आपको याद रखनी चाहिए. One rare variety is CET. What is CET? This is what is very interesting. The CET is a type where the ureter is coursing and trying to enter into the bladder from below. So बच्चे अगर ये यहां पर ओपन हो जाता, आई वुड से एक्स्ट्रा स्फिंक्टेरिक. अगर वो ब्लैडर नेक पे ओपन हो जाता, आई वुड हैव सेड दैट इट इज स्फिंक्टेरिक. इट ट्राइज टू एंटर बिलो फ्रॉम बिलो, बट it doesn't merges at the level of bladder neck. Majority of the tract is below the bladder neck. It goes below, but still manages to enter into the bladder. Majority of the terminal portion of the ureterocele is below the bladder neck, but the final opening is inside the bladder. So you can say that the tract goes below the bladder neck. Point number 1. But retraces and enters into the bladder. That means opening is into the bladder. This variety is known as CET. So अगर आप ये वाली इमेज देखोगे, so you can understand very well that this is the normal and this is the abnormal. Majority of it is below. Can you see it has gone below? But again it comes up and the opening. So this variety is what you are seeing is what? The CET. आपको पता है stenotic type कौन सी होती है? Obstructive. Sphincteric and extrasphincteric or ectopic type. What is ectopic type? If it is below. So what are the types of ureterocele? Sir, it could be located inside intravesical. Sir, sphincteric at the bladder neck. Below that it is ectopic or extrasphincteric. Then if it is associated with a component of stenosis, it is known as a stenotic type. So it could be sphincterostenotic, it could be ectopic stenotic. So this is what is very important. और लास्ट कौन सी होती? CET. अब आपने बाकी सारी चीज़ें तो रटी होंगी, that cobra head appearance, adder head appearance, blah blah blah, वो सब छोड़ो. And what is the management? It is the endoscopic de-roofing of the cyst for the intravesical part. Many a times it may be associated with the reflux. So if it's a duplex ureteric system, you have to ligate off and close the internal opening. If it is associated with the single ureteric system, you need to reconstruct the anti-reflux procedure in this. So that is, you know, the Cohen's trigon or Leadbeater polyteno, whatever feels like. बच्चे फटाफट let us go and move in front. Okay, और एक दूसरा क्वेश्चन, yesterday we have done all these questions. Okay, ये क्वेश्चन देखते हैं. I forgot this to ask this question. So identify a patient. This is the intervention procedure done for a patient. I also practice this procedure at my center. We have done at least 5-6 cases in the last 6 months. The results have been good क्योंकि cosmesis is of paramount importance. So पहली चीज, this process is done for chronic venous insufficiency, but there's a particular category जिसके लिए associated होती है. First of all, I want to know that. So it is done for perforator incompetency. So what is this procedure known? What is this procedure that you are seeing in front of you? This procedure is known as SEPS. What is SEPS, students? This is what is very important. This is known as subfacial endoscopic perforator surgery. बहुत ही अच्छा सा प्रोसीजर होता है बट थोड़ा सा टाइम कंज्यूमिंग होता है. ट्राई टू अंडरस्टैंड what is it indicated for. This is indicated for perforator incompetency. Whenever the perforators are incompetent, we will go for SEPS or we can go for the stab avulsion. So what are the things that we have? So for perforators, if it is incompetent, what are the interventions that we have? Remember, we have 3 interventions. The first is stab avulsion. Stab avulsion, I'll explain you, don't worry, it's a very easy procedure. The second is we have motorized phlebectomy. Motorized phlebectomy. And what is this motorized phlebectomy, also known as, or powered phlebectomy? This is also known as Trivex. Trivex is a brand name. This is. The next is, and the last is, the third is we have SEPS. बच्चे समझने की कोशिश करो करते क्या हैं तीनों में. This very 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 easy. So whenever you have the perforator incompetency, the patients come to your clinic or hospital, the very next thing that he wants is, sir मेरे को treatment बताओ जो सबसे अच्छा हो. So you will tell about all these treatments, but do you know, then he will ask you what is the charges for them. So if he has a good paying capacity, so latter 2 are there. But if he is not having paying capacity, you will not let the patient go. Rather, the first and the most easy is the stab avulsion. If you don't know about the others, don't do. पर ये तो बड़ा easy है. Try to understand what is the concept of perforators. You can understand that perforators are the defective channels. So you know you have superficial venous system, and in between superficial venous system and deep venous system, you have multiple channels which usually allow the blood to go from superficial venous system to distal venous, you can say deep venous system. Now if the walls are dysfunctional, the blood shall enter from these perforators and reach the superficial system. And that is why how to clinically identify, ये आपके एग्जाम में क्वेश्चन पूछा है, pitting on the facial, you can say, examination. So whenever you are examining, the fascia has pitting, and this facial pitting, whenever you suppose there's a pitting at the level of leg, what is this known as? This is known as a Fegan's test. So clinically, how to examine clinical examination will show you the pitting at the level of the what? Incompetent perforator. So whenever there is pitting at the लेवल ऑफ इनकॉम्पिटेंट परफोरेटर, बच्चों इसको कहते हैं फीगन्स टेस्ट. इसको कहते हैं फीगन्स टेस्ट. छोड़ो, अब उसके लिए मैनेजमेंट क्या करते हो? सो व्हाट यू डू with a simple 11 number blade. So you will make an incision, and once you make an incision, the very next thing is you need to hook the perforator. So you will hook the perforator. So hook out the perforator, then get this 11 number blade. So you can understand this is the 11 number blade that you have, and with this blade you just cut the perforator. So when you cut the perforator, imagine this is the wound, this is the perforator which has been avulsed. Normally when you want to ligate a vessel, how do you do this? Normally if I had to do, I would have simply ligated it at this place, and got a scissor and divided it. But this is known as ligation and division. This is ligation and division. Don't get confused between stab avulsion. In stab avulsion, you just avulse it. Now you will say, sir, bleeding will start. Don't worry. These are the subfacial. So with the one single bite, these facial suture, these facial defect can be closed and the vessel can also be closed. So बच्चे इस procedure को कहते हैं stab avulsion. So wherever you have the perforator, you will have to make a stab, and that is why cosmesis will be destroyed, क्योंकि अगर 10 perforator है तो 10 जगह कट हो जाएगा. अब फीमेल कहती है, डॉक्टर साहब पैसे की कोई टेंशन नहीं है, मेरे हस्बैंड ने पैसे देने हैं, आप बेस्ट चीज़ करके दो. बेस्ट मतलब टांगों में एक जगह भी दाग नहीं होना चाहिए, एकदम इटालियन फ्लोर की तरह, पत्थर की तरह चमचमाती हुई टांगे होनी चाहिए. सो दाग नहीं होने चाहिए, पैसा जितना लेना हो. मैंने कहा ठीक है, दिस इज ओके. सो फॉर देम यू नीड टू अंडरस्टैंड दैट वी हैव to enter into the subfacial space. So this is the knee joint, and this is the tibial tuberosity. 5 centimeter distal to this, we will establish 2 ports. We understand the fact that this is the superficial venous system, and this is the deep venous system. Students, I'm not getting time because of my ultra busy schedule. I'm not able to upload at least 5-10 surgeries, new surgeries in the surgical video column, and they're very interesting. But again, now I have decided that this weekend I will take out time, do some editing and just upload it. So we will establish the ports. So these are the ports that we have established, one 5 mm or one 10 mm, or you can simply, आज की डेट में तो हम सिर्फ we use harmonics, so we don't require 10 mm, we require only 5 mm. You can use a 5 mm telescopic port also. So anyways, via one your telescope has gone inside, so you can look. Now you will get your harmonic or you can get your clip applicator. In the subfacial space you will clip these dilated perforators, then you will get your scissors and then you will divide it. बच्चे you can use simply a ligashore or a vessel sealer NCL and simply एक ही बार में सीधे उसको काटते हुए निकल जाओगे. This is known as subfacial endoscopic perforator surgery. So this is SEPS. अब एक बच्चा कहता है सर वो भी बता दो वो भी. Trivex is not routinely practiced in India, but still if you want to understand what is Trivex, Trivex is just like Bahubali's chariot. You remember that Bahubali's chariot, that Ballal Dev's chariot in movie Bahubali. Matlab there was a rotating blade and that blade was rotating so swiftly that anyone who came in front of that blade, yes, was divided into half like this, है ना, ऐसे वो blade was divided. So remember that Bahubali's chariot and do it in a miniature. So this is a micro blade with a motor. So very same thing you are going to do. You are just shrink this. Let me shrink this Ballal Dev's chariot to a very small, and under the ultrasonic guidance I will introduce it, and then I will advance it in the subfacial space, and you can say so under the ultrasonic, you can say ultrasound guidance, I will divide it. I will advance it to the location, I will switch on the motor, it will divide. Switch on the motor. Now you will say, sir, what about the pressure? What about the bleeding? So बच्चे post surgery you will do a compression on the wound, and this is how you control the bleeding. So this is all for today's session. Again we'll meet tomorrow. Every day up till 15 I'm going to get something new for you. Remember, मैं वो आलतू फालतू images नहीं share करूँगा, but I will share you all the high voltage topic which you can dream of. Remember, Surgery Dada is the only platform where you will find each and everything. Still, if you have any doubt, go to my lectures, check them out, and do recommend Surgery Dada to your friends, to everyone who is still, you can say, suffering from that fear of surgery. One more thing, whatever be the exam, this is just the exam. Don't take any tension, don't panic, behave like surgeons. जो होगा देखेंगे. Once we get inside, then we will see. Give your best, and stay away from all those controversial questions. So till then, bye bye.